ahead and talk now about Aprv. So, airway pressure release ventilation is a mode that is not used that often, but is a very good mode for patients that are not oxygenating at high pressures, high mean airway pressures. It also allows for spontaneous breathing while you're doing a little bit more aggressive ventilation. These patients, like ARDS patients, pneumonia patients, this is something we can use prior to maybe trying the oscillator or other interventions. So it helps in recruitment and oxygenation. So the settings on Aprv are a little bit different at first when you first learn them. You're going to start out today with a high pressure of 20, a PEEP of 0, a high time of 4 seconds, so an inspiratory time of 4 seconds, and an expiratory time of 0.7 seconds. Go ahead and just put 21% FiO2, and your pressure support you can leave at 0. These are pretty standard settings for Aprv. You will most always see a low pressure of 0 or 1 or 2, very, very low PEEP pressures. Your inspiratory pressure is usually set 2 to 3 above what your mean airway pressure was prior to switching to this mode. And your high time and your low time are used to generate a rate. On this form of ventilation, we usually want a fairly low rate, so we allow for more time for recruitment and oxygenation with that higher mean airway pressure. So, with these settings, you can see we have a really, really long inspiration and a very, very short exhalation. So there's something very important that we need to measure. It's called the trap percentage. So it's the percentage of air that is trapped within the lungs. And we can see right here, your exhalation is not reaching baseline. We can also call that auto PEEP. So we want that anywhere between 25 to 75%. So if we look at our expiratory rise, our flow line there, we can see that we're about probably 25%. We can adjust that if we change our expiratory time. So we just increased it probably to closer to 50%. So that trap time is what keeps air in the lungs to help with that re-recruitment and that reoxygenation. Now, when you're in Aprv, you do want your patient to be not sedated and not paralyzed. If they need to be slightly sedated for comfort, that's fine, but you want them to be able to breathe on top of this, on these settings. So you can put pressure support in if necessary. Oftentimes you will see no pressure support. So if we look at our tidal volumes, we're getting at about 810 mils. We have a PEEP of 3, so we are trapping, which is what we want, and our peak pressures are 23. So if we have a change in compliance for our patient, if we take our compliance from 40 to say 20, what would we expect to happen? Same thing as before. If we're in a pressure mode and our compliance decreases, we're going to expect to see a change in our volumes. So our volumes will decrease. Now our peak pressure shouldn't change too much, but let's go ahead and make the change and see what happens. So we went from 810 mils tidal volume to down to maybe half of that, maybe 400 mils. So you can see a significant change. Also, if you look, your expiratory flow has reached baseline and you are not really auto-trapping anymore. You don't have any PEEP, any residual PEEP. So with that being said, you would want to either adjust your settings based on your patient's change in compliance or see what's causing the change in compliance and try to correct it. So we did see a change in our tidal volumes, not so much our peak pressures. And that's what we would expect with a change in compliance in APRV.